All right, if we can all convene. So thank you everybody for being here. Welcome to our Public Health Forum for those in person and those online. For those who I don't know, I'm Sano. I have the privilege of serving as Dean of the School of Public Health at Boston University. The Public Health Forum is our monthly premier academic presentation of the calendar, and usually we target topics that we think are of real deep scientific interest and bring a world leader to talk about such a topic. And today we're talking about preventing memory loss and dementia, and we have an outstanding lineup for this evening. So let me tell you a little bit about what we're going to do today. We have a slightly different lineup than usual. We have an expert talking about the topic, as we always do, but then we also have a journalist who is going to be helping us sort of take the topic to a different level in conversation. So let me just introduce the speaker and the journalist. So we have Professor Mary Sano, who's a professor of psychiatry and director of the Alzheimer's Disease Research Center at the Icahn School of Medicine in Mount Sinai in New York City. This was I worked at New York Academy of Medicine for a while, which is exactly neighbor to the Icahn School of Medicine, but we met in Boston. We did not meet when I was there. She's also Director of Research and Development at the Veterans Administration Hospital, the James Peters Veterans Administration Hospital. Professor Sano is a neuropsychologist by training, but has been involved in conducting clinical trials for Alzheimer's disease, Parkinson's, and cognitive impairment of aging for a long time. She has a long, distinguished career in the field. She, in particular, has directed the first multi-center trial demonstrating effects of vitamin E in delaying clinical progression of Alzheimer's disease, which I think is a really interesting angle of prevention of memory loss and dementia. She serves on a number of boards. She's president-elect of the International Psychiatric Association and member of the Medical Scientific Advisory Committee of the Alzheimer's Association, and she is a recipient of the Lifetime Achievement Award from the Clinical Trials on Alzheimer's Disease. That's Professor Mary Sano. Then we have Kay Lazar. Kay Lazar is a health reporter with a focus, long-term focus, on aging, sports medicine, and public health. She's been has more than 2 decades experience of print and broadcast reporting, and has previously worked as news writer and producer at ABC and CBS radio networks. So Professor Sano is going to do a presentation, and then Kay and Professor Sano will have a conversation about the topic and engage everybody in the audience in that conversation. Thank you both for being here. Professor Sano.
Well, thank you for this invitation. I really appreciate being invited back to Boston, which is actually my home. So it's been a while, and I appreciate seeing such a nice audience. My topic of preventing memory loss and dementia is going to talk a little bit about what we do, what science we have collected, and what we need to do, what's yet to come. I wanted to comment on the fact that I use the term memory loss, but in fact, when we're talking about dementia, we're often talking about a broad range of cognitive losses, although memory is the loss that's most noted, particularly in Alzheimer's disease, and also in other diseases of aging. So this is just a quick review of the things we're going to talk about. I'm going to just tell you about how far we've come briefly in terms of diagnosis and treatment, and then to tell you what we know about lifestyle and what our next research steps are. So I was just saying to Kay, this is a slide I've been showing for probably decades, but it hasn't changed. The population over 65 is the fastest growing age segment. The number of elders results both in a greater incidence and prevalence of Alzheimer's disease and other dementias. With increasing longevity, once you get the disease, we're more likely to live with it longer. And here's the most important part. It's become part of our lexicon, but in fact, we know that there's this 3 to 5 year period of mild but significant cognitive impairment that precedes diagnosis. And we've referred to that term in the past and in the current present, in some cases, as mild cognitive impairment. It has new terminology in all of our diagnostic criteria, but we're clearly aware that there's a period when their cognition changes, we're aware of it, and function is not so easily observed as being problematic, except for the last bullet here, which is changing technology. And technology is almost by definition always changing, really requires that cognition be maximized. We need to be able to interface with technology that changes routinely to do anything, to pay a bill, to get our medications, to do anything. And so while the disease that we all worry or think about when we say Alzheimer's disease or dementia is the end stage, in fact, this stage is a stage that really can give the patient themselves the most concern and worry. This slide collects data from 2006 and 2010 pointing to the fact that Alzheimer's disease is a growing fear. I saw recent data in 2015 that suggested that Alzheimer's disease had actually exceeded in the worry and fear about Alzheimer's disease had exceeded cancer. That may be because of a possible misunderstanding that cancer is now completely treatable, and those of us in the medical field know that isn't true. But we also know we haven't made great progress in treating or curing Alzheimer's disease either. So while there's a great deal of angst that we don't have answers, I think it's important to realize we do know things that we did not know in the past, and that we need to believe in those things and perhaps act upon them. So first of all, we have improved confidence in the diagnosis of clinical evaluation. For years, people would say, oh, you can't really tell, but there are new markers that allow us to know with greater confidence the type of dementia. This is through imaging and other biomarkers. The risk of apolipoprotein E4 is well accepted. In fact, the risk is being understood through certain mutations that might even help us know exactly when onset would be. At least in those are the quest of our research studies. We do have treatments that have been approved for Alzheimer's disease and for dementia in general. And I think it's important to realize that the effect, though modest, is really robust. Every trial that examines cholinesterase inhibitors sees an effect. It is small, it is not sufficient, but it is present. And I would argue that we have replicated the evidence of functional benefit of vitamin E demonstrated in individuals who have mild to moderate Alzheimer's disease, but unfortunately not yet as a preventative, and possibly not, since the benefit here is on function and not on cognition. So I wanted to give you this sort of overall slide that talks about potential pathologies that lead us to dementia. But it is clear that cognitive decline precedes dementia. Now, there is also a belief that the pathology precedes the cognitive decline, but this may not be so well established, and we'll talk about some challenges to that concept. But clearly we know that cognitive decline occurs because of aging and certain genetic influences change it. In terms of Alzheimer's disease, we're aware of the impact of amyloid accumulation, but it's also important to remember cognition is impacted by vascular risk factors, other changes in the brain. And these changes have impact on lots of aspects of brain function. So we know there's synaptic dysfunction, there's activation of inflammatory mechanisms with glial. We know about neuronal death. We know about not only amyloid but tau accumulation. And the concept here is this whole range leads us to cognitive decline. Now, in this slide, I'm showing you data, metadata, that was collected from the Alzheimer's Disease Research Centers many years ago. Basically, what this slide shows, and I would say no one would disagree with this, that if an individual's performance is below what would be expected for their age, and here we have individuals who were below, didn't matter what memory test it was, and those who are above. And what we see is in those who are below, just the memory test alone, separate from all of the biomarkers, actually does predict very highly a conversion to from cognitive complaint, cognitive impairment to dementia. What's of interest here is that over 3 years, about 45 to 50% change. If you follow out to 5 years, about 75% changes. But there's about 20% that never change. So there can be individuals, that's 1 in 5, who do have this cognitive decline, but it's a non-progressing cognitive decline. So I just wanted to review this risk factor issue for you. The apolipoprotein E genotype, there are 3 types, 2, 3, and 4, and we each have 2 alleles. So we can have 1 or 2 representations of the E4. Dramatically increases the risk of Alzheimer's disease. This is the one risk factor that occurs throughout what we refer to as sporadic Alzheimer's disease that stays very strong. The allele strength, the risk increase is from 3-fold to over 10-fold, depending on whether it's 1 or 2 alleles. Of interest, in the original guidelines in which we discussed this, which is back in 1995, it was really not recommended to consider ApoE except in the presence of dementia to perhaps identify the type of dementia and to provide greater diagnostic confidence. But this has been reconsidered in the 2011 diagnostic criteria. There was a suggestion that using genetic markers may be important to helping people evaluate their risk, especially in the presence of the mild cognitive impairment. As I mentioned, there are clinical trials that have demonstrated the effect of cholinesterase inhibitors on and memantine, a GABAergic agent, on cognition in Alzheimer's disease. Most of those were short-term trials of about 6 months that showed an improvement on cognition. There's been epidemiological studies that have suggested that it may actually improve survival. This is actually a randomized trial looking at one of these agents, galantamine, that is showing a survival benefit as well as a 2-year benefit on a cognitive test, the MMSE. So in fact, in these even long-term trials, these treatments, which we say don't do much, actually make a difference in terms of both survival and cognition, even over 2 years. So it's true it's not enough, but it's really important to know that in '92 there was nothing. And so it's a move that we need to pay attention to. The other thing that I think is interesting is this is a study that demonstrates that even in individuals who are severely demented, the treatments of cholinesterase inhibitors and memantine actually continue to have a benefit over placebo. And this is up to a year in these more impaired people. So it's easy to say we have nothing and nothing works, but in fact the data suggests otherwise, and the nihilism may be around the fact that we're treating a very terrible disease in older people. However, this benefit, this size benefit in a younger population might be considered worthwhile, so we have to think about what would make us concerned that something was truly working. And finally, this is the data from the replication study of vitamin E. This was done in veteran population, randomized clinical trial looking at vitamin E, memantine, and placebo, and showing an effect on the activities of daily living. And this effect was seen in individuals who had mild to moderate disease above and beyond the benefit that they received on their standard of care, which were cholinesterase inhibitors. So in fact, this small benefit is above and beyond what's been seen previously, and it actually does replicate findings that suggest that vitamin E might have a functional but not a cognitive benefit. So I promised to talk about prevention, and that's where I'm going next. This slide is almost out of date. The National Institute of Health and the NIA in 2010 put together this State of the Science conference to describe what we know about prevention of cognitive loss and dementia and Alzheimer's disease. And basically the summary was that there really is no support for any pharmaceutical, dietary supplement, lifestyle intervention. However, there was promising research. So it wasn't to say they did not work, it's to say we just don't know. And here's a place where we just don't know. There was some suggestion that antihypertensive medications may have a beneficial effect, omega-3s, physical activity, and cognitive engagement. Now, here we are, 7 years later. And this review has just been reconducted. It was contracted by NIA and conducted by the National Academy of Science, Medicine, and Engineering. And I have just participated in the review of the final document. There was also a public statement, and most of what I'll share with you is what was said in the public statement. And I'll try to review some of those data for you. So what do we know about lifestyle and what we call modifiable risks? Well, here you have a whole series of potentially modifiable risks and interventions that could be considered to improve diet and lack of physical activity, stress, head injury. There's an epidemiological connection from many of these, but there's very little clinical trial evidence, although now it's starting to appear, and the effects are not exactly what we were expecting, so I'll walk you through some of them. The thing to keep in mind is that it might be an indirect pathway. It might be that observing in a short period of 2 or 5 or even 7 years the effect directly on cognition of these interventions is not possible. Some of these interventions are known to affect cardiovascular risk, so perhaps there's an even later outcome past the cardiovascular risk that might give us an opportunity to see a benefit. But I can tell you where we stand now, what we know, what we don't know. So the first thing is what were the estimates? So this is data that came out of Christine Yaffe's work, in which she suggested that these 7 risks accounted for 50% of Alzheimer's disease. The question is, can we really reduce those risks and see these kinds of benefits? And in fact, there's not a lot of evidence that reducing some of these risks, although there are a few that remain important, and we'll go through them. Now, there are a couple of ways to do this. One is to take each of the interventions and look at them individually, but we all know an integrated approach might be the better and most obvious way to do this. And so I'm going to start by showing you 2 studies that looked at this sort of integrated approach. The first is the finger study, which I'm sure you've heard of. It got great press in the past 2 years at the Alzheimer's Association, the AAIC meetings, conducted in Scandinavia and recruiting individuals who were in a risk age period, 60 to 77. They had a dementia risk score of 6, which was based primarily on cardiovascular risk. So it was a dementia risk score, but based on the risks we now think of as cardiovascular disease. In addition, individuals had to have one or of these criteria. So the highest mini-mental was 26, right? Or they could have poor performance on a word list test in either immediate or delayed recall. So that brings us a little beyond cardiovascular risk, because we know that vascular disease is a little bit less likely to have an impairment on memory and more likely to have on executive function and processing time. So this is the cohort that was recruited, and I've forgotten how I went for it. There we go. And here's what they did. The control group well, let's start with the intervention. The intervention was along multiple domains, and the individuals who participated had extensive interventions. They saw nutritionists, both individually and in group. They saw physiotherapists to improve muscle strength and aerobic exercise. They saw a psychologist who conducted cognitive training, and they had social activities that were conducted through group exercises. And the control group, same people who have these risks, right? They saw a nurse who gave oral and written information and advice on managing the same set of risk factors. And in particular, they focused on diet, on physical activity, cognitive, and social stimulation. So here's the results of the study. This is a 2-year results, and it's been a very interesting history from the time of report to current discussion. In this 2-year results, the primary outcome that was pre-stated was this NTB, neuropsychological test battery, which actually did show some separation. The other 2 domains that showed separation are processing speed, which is timed test, and also the executive functions, which were measured through a timed test. What's particularly interesting is there's no separation on memory, right? And the most important thing to remember here is to be recruited into the study, you needed to have some borderline memory deficit. So we do see that the intervention can improve those things that are associated with overall cognition, in particular processing speed. But the one cognitive domain that we think of as most associated with Alzheimer's disease has not been changed here. Nevertheless, those other domains remain very important. Well, a similar study was conducted, the PREDIVA study was also conducted around the same time interval. And the intervention here was somewhat different, although follows the same model. The interventions were delivered by a practice nurse, and there was control over the same kinds of cardiovascular risk factors. Smoking was an additional one. There was a focus on control of glucose and lipids. And on the basis of the assessment, the individuals' programs were individualized and provided to the participants based on what their risks were. So this study was done a little bit differently. It was a cluster randomized trial with individuals who were in the same age range, a little bit older, but in the same age range. And the assignment for the clusters, it was randomized as it was in the other trial. But it's a longer observation period of about 6 years. And here the primary outcomes were incident dementia and disability on ADLs. And there were additional secondary cardiovascular disease modifications, and an intent to treat analysis was used. And what you see here is there's really no separation over the 6 years on the primary outcome of incident dementia. None of the other outcomes showed statistically significant separation. But the one thing I wanted to point to was that, let me see, there we go, is that when you look here, 4 years, not as early as 2, but you do see a little bit of separation. I think what's interesting is that this study allows us to know about a broader separation over a longer period of time. And over the longer period of time, it was hard to sustain these benefits in a meaningful outcome. So what about specific interventions? Diet, exercise, cognitive training, sleep, supplements, that whole body of other specific interventions as opposed to this whole all-encompassing multi-domain approach. Well, there's been much reported on the Mediterranean diet and dementia, and the concept here is individuals whose diet falls into a pattern of Mediterranean triangle of food intake seem to have a better likelihood in epidemiological studies of avoiding dementia. And in fact, when that diet was examined in a relatively large cohort in Spain, it was identified that it could reduce cardiovascular outcomes. What these graphs are showing is the particular benefit from the both Mediterranean diets that increased oils and fats, and in some cases a somewhat better this is increased fats through either nut or olive oil, and here it's nuts or olive oil. I think there's a slight benefit in terms of olive oil, but both of the Mediterranean models had some effect. Right? Now, what about cognition? Well, cognition was tested in a subsample, but a relatively large subsample of this group. And what you see is that over a fairly long observational period, nearly 6 years, I believe, there was a small but significant benefit in overall cognition as measured by the MMSE. Only the MMSE. I think it's really important to see how small the benefit is. So the delta in this study is less than a point on the MMSE in this cohort of individuals. Now, another thing to keep in mind is this cohort was cognitively more intact than the cohort we just saw, right? So in the more intact cohort, it is more difficult to see a benefit. And it may take longer, but it is important to realize that if there is a deficit, you're going to be more likely to see an improvement. And that's a little bit different than what we think about when we think about prevention. So I want you to keep that in mind as we talk later. So what about physical activity to benefit cognition in the elders? These are the results summarized from a Cochrane collaboration. I believe it's been updated since this summary, which I believe is around 2012. It reported on 8 studies. It reported on 11 studies and found that the majority of them showed a benefit in physical activity. In particular, aerobic exercise seemed to be the one measure that improved function, although there have been some studies that suggest that there's a wider range of physical activity that gives us a benefit. However, the challenge in these observational studies is what are we looking at? What is the population and what is the outcome? And how will we measure it? And so one problem across these studies is there's no really consistent effect. However, I think one of the most striking studies that I've seen is this work by Erickson, reported in 2011, looking at individuals who were either given aerobic activity or stretching. And basically what you're looking at here is 1-year data and hippocampal volume. And what you're actually seeing is a very nice increase in hippocampal volume with the aerobic activity. Now, what's interesting is that this is the one place where the separation is significant. The part that's interesting is cognitive performance in both groups were not different. So the improvement in cognition did not change, but there was a change in hippocampal volume. Interesting, again, saying is 1 year sufficient time to actually measure these things and know whether or not we're having an effect. Okay. So the reason I show this study is because I think the concept of physical activity is really universal, and it comes from one of my trips where I recall that it was sort of expected that people across all ages engage in physical activity. What you see is this group who are age 49 to 84. I'm not sure they were necessarily doing it for their cognitive benefit, but rather for their quality of life. So here is one of the most impressive studies on physical activity. This is the LIFE study. It engaged individuals who are sedentary, men and women between the ages of 70 and 89. So look, we're looking very old here. High risk of mobility disability, and that was the primary outcome measure. They wanted to prevent mobility disability. Individuals had to be able to walk 400 meters, but the idea was that that is not sufficient, and they wanted to see if they could improve gait. They were randomized to this physical intervention that was with a trainer 3 times a week, and then self-administered or self-participation. Or they were randomized to a health educator in which they had a comparable amount of exposure to intervention where they discussed the importance of healthy lifestyle. So this study was reported out and demonstrates a very impressive and significant benefit to physical activity in reducing mobility disability or minimizing persistent disability. And those were the measures that were performed here. However, the study had a planned secondary analysis for cognition. And in fact, no one who had dementia was admitted to the study. And dementia was assessed at the very beginning. It was not an add-on study. It was part of the planned secondary analysis. This was reported, actually that's an error, it was reported in JAMA Neurology last year. And in fact, what you see is that physical activity is not associated with less mild cognitive impairment or less dementia. Now, these effects are not significant, but it's 2 years data in the wrong direction. And this gives one pause. Could it be that the group is too old to initiate this without some risk to cognition? Could it be that there's no difference in the two groups? Or is it suggesting that over a longer period of time, this risk could actually grow? It's disheartening. But in fact, it's something we have to integrate into our model as to whether or not mobility disability is really, whether or not physical activity is going to help cognition. But as I mentioned, I think it's important to pick people who might actually be able to have an improvement or a benefit. And that's the idea of something called the EXERT trial. This is going to recruit people around the same age range, but they're selected based on the fact that they have some form of MCI, mild cognitive impairment, either amnestic or multi-domain. These individuals will have a mini-mental that's high enough so that we know that they're not truly demented, but have a possibility of seeing some benefit. Impairment on delayed recall is also part of this model, again, often to ensure that we're looking at the risk of Alzheimer's disease, though it's not necessarily a guarantee. It's a pretty intense intervention. It requires an informant or a study partner, and it'll require regular visits to a Y, which will engage in 3 to 5 times a week physical activity. But it may be a place where we can sort out a benefit because, in fact, there's something to improve. There's some lowered performance for which we can hope to see a benefit. I would say that sleeping disorders have only recently come into light, and I just thought I would take this one study and mention it to you. I think in the next, if you ask me what's coming next, I think it's attention to sleep. And we do believe that sleep, or inappropriate sleep, lack of sleep, circadian disruption, can have an impact on cognition. And that's probably true across the lifespan, and may actually be worse in the presence of aging or other brain risk factors. So it's been associated with other features that have their own direct association with cognitive loss, including increased body weight, reduction in cognition has been noticed across the ages, and an earlier age of mild cognitive impairment. And this is a place where I'm really excited because long before sleep became its own study, I have to tell you, I have never seen a cognitive benefit bigger than the benefit of CPAP on cognition at any age. Right? So if anybody's sitting at home not using your CPAP, please rethink it. It's the most dramatic cognitive effect I've seen in very well randomized clinical trials. Now just remember, if you don't have sleep apnea, I can't tell you that adding CPAP will make it better, right? We can't cure what we don't have. So sleep disordered breathing is only one form of sleep disturbance. And I thought it was worth taking a moment to look at this data that suggests that those with sleep disorders breathing have an earlier onset to MCI and dementia, and that CPAP reverses it. So this is in terms of MCI, but this data is long-standing and it's conducted in randomized trials, not simply observational data. Okay. I'm going to skip over that. Okay, so here's another slide I wanted to show you. So here's one agent that has been studied, and we'll look at one or two supplements to see whether or not they really have a benefit on Alzheimer's disease. So the MIDAS study was a study that looked at AAMI, age-associated memory impairment. So this was a mild cognitive deficit, and the individuals were not expected to be moving on towards dementia. But let's face it, we do care about cognition in general and aging. The idea was DHA may have a benefit, and omega-3 could improve function. What is really important in this study that no one seems to recall when they talk about going out and taking massive omega-3s is that the study selected individuals who had low dietary omega-3. So for example, any good Bostonian probably has more than 1 or 2 fish meals a week. And if you do, you were not eligible for the study, right? So again, remember, this is a lower than what would be considered a healthy level, and we're treating that level. And what was found in secondary analysis, this was a real challenge to this study because it was not the primary analysis, was a change in paired associate learning that's pretty dramatic and measurable. And so I guess I would say, if you don't eat fish, you might consider this. But it is important to realize that the supplement was to supplement something that was probably lower than normal. On the other hand, we have the ginkgo biloba study published several years ago. I think the reason I always present this study is because people say, well, we don't know what works and doesn't work. And in fact, this study was a failed study with no effective ginkgo biloba. But the reason I present it is because it shows that we were able to plan the study, select the population. What you're looking at is the expected amount of deterioration or change from non-dementia to dementia. And the survival of the cohort and the follow-up was good. So we actually do have the methodologies. It's not that we don't know how to measure this. It's just that this does not work to delay the onset of dementia. All right, so I've told you about many lifestyle changes. This is always more, and we can talk about them later. But when all is said and done, the question is, how are we going to prevent dementia? And do we go, in particular, in talking about Alzheimer's disease, about changing the pathologies that are prominently associated with Alzheimer's disease? And now I'm going to talk about some clinical trials that are examining experimental therapeutics for amyloid lowering. And why amyloid lowering? Well, first of all, amyloid is now readily measured in the brain. It exists as a clinical test to determine if a person has actual Alzheimer's disease in the face of their symptomatic disease. It's being used experimentally to see if presence of amyloid would predict worsening cognition. Why not tau? Well, we are just beginning to be able to measure tau, and the agent development is just starting. I'm sure we're going to see that soon. And why not the other major marker, which is cell loss or synaptic dysfunction? And I can tell you that may be coming down the line because we're now developing the tools to measure those things. We're developing imaging techniques to measure synaptic loss and synaptic dysfunction. So that may be what's coming, but this is where we are now. So where does this idea come from? Well, I have presented this data many times, and I have some concerns about how really strong it is, but let's talk about it for a minute. This is data that is frequently presented to prove that you get plaques and tangles many decades before you get symptoms of Alzheimer's disease. And the first graph is a graph that summarizes data from 3 cohorts looking at medical examiner databases to see how much amyloid is in the brain of individuals who died at the medical examiner's office. And what you can see is amyloid is visible and growing in the brain starting at early 30s and peaking. And the second line is the prevalence of Alzheimer's disease in its primary ages of onset. And so what you're seeing is that the green line ascends before the red line. And this has been used, some of this data in the pathology has been replicated with imaging studies to see the amyloid in living individuals. But the idea is that this occurs 15 years before symptoms. Well, it's potentially possible, but our actual number of asymptomatic cases has not been coming in until the very highest decade. So we're not really sure how much we can depend on this approach. Let's assume it's real and see if we can prevent dementia by this model. So the idea was anti-amyloid treatments for individuals who are asymptomatic but have amyloid in the brain, right? This A4 study is actually led by Risa Sperling, who's here in Boston. It's gotten a fair amount of press, and we'll talk about what some of the limitations and possible next directions are. In any case, these individuals have normal thinking and memory. Their performance has to be within the normal range. But they may be at risk for having memory loss because of positive amyloid scans. And the treatment is with solanezumab or placebo, and the idea is to reduce the rate of memory decline. So first of all, this is evidence, and this is only one set of slides that show you with one agent, that there are healthy controls who can have relatively strong amyloid accumulation, despite the fact that their cognition is quite stable. And this is the probably most significant data that goes with that, the behavioral data, that's looking at 2 different measures of memory in people who are either asymptomatic or mildly symptomatic and have either have amyloid or do not have amyloid. And I think what's really important is to see that in general, these groups who, they're not above average, they're at average, have the ones who are amyloid positive and are normal have a deterioration in their performance on verbal memory and also on visual memory. Okay? So let's look at this. This is a 1-point drop in a verbal memory test over 36 months. So think about that. If you're 65 and that's what you have, that's disturbing. If you're 85 and that's what you have, in any case, we are opening the door to have people tell us, I really am worried about my cognition. I don't care how old I am. It's worthy. I'm valuing the intervention enough to participate in trials in which you might lower this risk factor for me. The other important observation here, which I think is relevant, is these are the individuals who have MCI, and those who don't have amyloid, a portion of them actually get better over time. But the portion that do have amyloid actually have lower performance even at the beginning of the study. So it's not clear from this which comes first. So the agent that's being studied right now is a solanezumab, a monoclonal antibody that binds to amyloid. It has been ineffective in some clinical trials. In fact, initially we described it as minimally effective in secondary analyses, but now we've had another 2 very large trials show that it is not effective in even the mildest symptomatic cohorts. So one problem here is that maybe the agent isn't strong enough, or maybe it isn't it isn't early enough, right? And we don't know, and we're talking in an adaptive kind of design of extending the sample size, increasing the dose, just to see where we are. Now, this is a study that you've probably heard about. This is an agent called aducanumab that has been studied in very small numbers and shown to actually rather dramatically reduce amyloid in those people who are amyloid positive, who are labeled as symptomatic but have very high mini-mental scores. It's 24 or higher with a clear memory deficit and amyloid positivity. So the dilemma here is that the risk of side effect with these agents is pretty strong, and our question is, how early would you consider this agent for even a prevention, right? Well, we have to move forward and see if in the symptomatics we can actually replicate the supposed effect size and just see if in fact we can see it at all. And then if we can see it, the question becomes how much risk for how much benefit. It's probably an individual matter, but from a public health standpoint, we might want to talk about how much cost for how much risk for how much benefit. Okay, so I'm actually done with most of what I wanted to tell you about. So when people ask me what can I do to minimize my cognitive impairment, the thing I have said all afternoon is treat your treatable conditions, right? So high cholesterol, diabetes, hypertension, depression, treating those entities, right, can't hurt your cognition, right? Protecting your brain, and then finally supporting research. And for everybody in this room, I'm sure you support it in one way or another. But here's the way that I find has been interesting. Think of the burden of participating in clinical research and in clinical trials. It's very easy to be on the side where we sign the consent form that says, oh, you know, you only have to come in 3 times for 3 hours, 3 weeks, this month and next month and next month and next month. There is burden, and I think we have to work to reduce that burden. But I think supporting research at the level of participation is a very big deal. And it is really the source, low participation is really the source of most delays in research. Of interest, very few physicians or providers refer people to clinical trials. And very few patients report that they've ever heard from a doctor that it might be worthy of being considering a clinical trial. And I summarize this because it is burdensome. And so I think it's really worth taking a minute to think about what everybody can get out of participating. And for clinicians who refer, I think they actually have an opportunity to learn about the cutting edge research and develop really meaningful relationships with people who are in tertiary medical centers working on a single focused disease. The big deal with patients is the most common reason is the last one. It is the contribution to self, from self to society. There is really altruism in our role, and that's something that no matter how cognitively impaired we are, we can actually always provide. So my last slide is to remind us that the job to support research is everyone's. It's not just simply participants. It's also clinicians, key informants, providers in the breadth of the community. And my other talk is how to get those people to do that. This is a slide that I summarized for a lot of people who are interested to tell them what things to think about. Choose, know that you can always change your mind, be honest about how much you can participate. So I'm going to end with this one, which is that everyone cares about cognitive loss and dementia. And I have to say, when I entered the field, that was not necessarily true. We've made progress, and we shouldn't forget that we've made progress. I think prevention is really important, but it's going to take a lot of people and a lot of time and a lot of effort. And I do believe that we can maximize cognition with lifestyle and environmental and interventions, but I really think it's going to require some form of pharmacological intervention to really get us where we want to be. That's my team, and thank you. Would you like me to say?
Sure.
Great.
Sure. Well, thank you. That was a lot to digest. One of the things when I was watching a lot of your presentation that I've read often as a challenge for Alzheimer's research is that a lot of these studies have trouble recruiting diverse participants. Often it's overwhelmingly white, overwhelmingly male. So I'm wondering, to that extent, with a lot of the studies you showed us, were many of them overwhelmingly white and male, and how does that affect the outcome and sort of, some of the findings? And
it's a great question because it leads me to tell you about one set of studies that I didn't describe. Studies that are conducted particularly by NIH or in combination with NIH and industry actually do really make a great effort to go out and maximize the breadth of participants. So the last study that I told you about, which is a collaboration with NIH and pharma, has just under 20% minorities, which is good. That's right around what we would expect that are screened and participated. The real dilemma is that in phase 3, 2 and 3 studies where you need to worry a little bit about safety, we don't know anything, we often exclude people based on comorbidities that are rampant in those populations. And the question is that a good idea? Or should we simply inform them about the risk of the comorbidity and let them choose? And I think that's a really important question about research. How much engagement of the community in making our designs? So,
another thing, and it spoke to some of your last slides that you said, here's what you can do, protect your brain, et cetera. If you had a loved one, I always ask researchers this, if you had a loved one who was just diagnosed with dementia, perhaps Alzheimer's, what would you recommend of all the lifestyle, the food, the activity? What would you recommend?
Well, I first of all, I'm a believer in the currently approved medications, right? So that's an area that takes a little bit of time to negotiate, getting people to the right dose and tolerating when it's given. And it's a little bit of management. And a lot of our primary care docs don't really have the time to do it. And even the ones who are willing, the families can get discouraged because the side effects can be a little bit disturbing. But a really large number of people are able to tolerate them. So that's number one. And I feel pretty strongly about this because I know that they're all, I think all of them are generics, and there's lots of ways to manipulate the dose. But there is a real nihilism about it doesn't make a difference. And I have to say the data does not support that it doesn't make a difference. It's true, it's not as big as we want it to be. But now that it's not an issue of cost, I think every little bit helps. So that would be number one. The second thing is hoping that I get someone who's diagnosed very early. I'd spend some time asking them what things matter to them, what things they really want to be able to do, and what things maybe don't matter as much or they don't care about. That can help you start your planning. I think that's a very big deal. In terms of all these interventions, I actually think that mobility is important even if it doesn't improve your cognition. So we just found out that mobility disability can be improved by physical activity. So even if it doesn't improve your cognition, being able to be moved around may improve how much you're being socialized. And then I think the socialization's a big deal. And the problem is, as person ages and dements, they can have fears about new people. They can have fears about introducing new assistants into the home. And I think doing that as early as possible, broadening the social scope as early as possible, really has the greatest likelihood of being able to support the patient and the family member.
Interesting. We were speaking before your presentation about your earlier trials with vitamin E, and then it's been replicated. And share that with the audience, because I think that was really fascinating.
Right. So, the study with vitamin E was looking at very high doses of vitamin E And it had a specific plan in the original study, which was back in '97, had a specific plan to look not at cognition, because at the time people were starting to say, what does a few points matter on the cognitive scales, but really to look at important endpoints: nursing home placement, death, the loss of all activities of daily living. And this was sort of a combined outcome. And basically, we actually did see an improvement a difference in the time to reaching those outcomes with vitamin E. That's a big deal. But it did not improve cognition. It didn't make it worse. It just had no significant benefit. And that has been consistent throughout vitamin E study in this range of dementias. So in mildly impaired or non-impaired, it does not improve cognition. I don't know of any studies where it improves cognition. However, even when we now have treatments, adding the vitamin E on top did provide additional benefit on activities of daily living. Same kind of functional outcomes, again, not on cognition. Not making it worse, but just not making it a little bit better. And the other thing that I was impressed with in both studies, there's been a very big concern about this high dose and bleeding risk. And in fact, there was no bleeding risk. And in fact, in this particular study, we actually very carefully measured prothrombin and saw no difference in it. So I think it's a relatively safe benefit that can occur on top of what we already do.
So, I mean, and I see a question out there, so I will. Is this something that you would recommend to people? I mean, you're not their physician, but
Right.
I mean, vitamin E seems so simple, and if it's
Right.
not in
So-
huge doses.
So I try to, if it was my family member, I would encourage them to try it. I would have them try it. But in fact, in general, I think the data has to stand where it is. It's the kind of data that I could use to support its use in treatment if it was my decision for myself or for someone I loved. So.
Did I see a hand up? Was there? Okay. Feel free to jump in and raise a hand because I don't want to hog. Please, go ahead.
Thank you. Question is about ApoE, and since I heard on the news that it's now part of 23andMe,
Yeah.
and there were questions about the validity of the test in that package. So I guess that's one question I have: is the test good enough? But second, you mentioned odds ratios for the risk if you have ApoE, but I'm wondering about absolute risks. If you could clarify
Right.
those. What's
So-
my chance of getting it if I have the allele or both of them?
Right. So the absolute risk is not.
What do I do about it?
Okay. So it's a dilemma, right? I mean, the ApoE allele increases the risk, but it is not an absolute risk. I have in my longitudinal cohorts elderly people who have 2 alleles and are not demented, right? Don't have symptoms. What is interesting is that it increases the risk, it seems, of amyloid as well. So an alternate model is to use it to decide to consider amyloid testing at the earliest stages. And I think the rest of hopefully what I've convinced you of is to treat your treatable conditions. You know, I wish I could tell you that you should take this, but I'm being honest, we don't know. We do know all of these things that have a potential beneficial effect, and I think that's important to keep in mind. So,
On the front row here? Oh, the mic. Yeah.
Thanks for taking my call. Question. So when I was a resident, this is back in the 90s, we always struggled with the impossibility of knowing whether our patients who had dementia were suffering from vascular dementia, or whether they had Alzheimer's disease. And it was sometimes if they had lots of strokes, we'd say, aha, it's vascular. And if they didn't, we would scratch our heads and say it's probably Alzheimer's, but we wouldn't know. But now we do know that with the floor PET scans, we can actually be clear. And I'm wondering if there's been some effort to go back and look at things like the ApoE work that was done in the 90s and recalibrate those genetic associations now that we have an actual biological endpoint that we can test it to get, to see what fraction of those with maybe a low odds ratio for the ApoE, single allele, whether those odds ratios would actually come up a lot once we exclude the noise from the subclinical vascular dementia folks. So curious about that.
Right. So in fact, the odds ratio of dementia, this is why I'm not, the odds ratio of dementia actually looks pretty close to the odds ratio for amyloid positivity. So, and we're not going back, but we're going forward. So as we're collecting imaging, and we're also collecting, there's almost no study, I can't think of a study that would collect imaging, amyloid imaging, that would not also know ApoE status. And so it really does very much look like the E4 allele predicts amyloid status. Now, I have to say, with the same odds ratio as it does dementia, I have to say the problem is amyloid imaging's not inexpensive, and so mostly people are not doing population studies of amyloid. They're doing amyloid in selected populations, although that may change. I believe there may be some amyloid imaging coming out of the Mayo study, which is truly a population-based study. So we may get more information that way. So,
There was a question.
Hi, thank you very much for your talk. I want to change gears a little bit to more social behavioral aspects. I think one of your early slides, you talked about what people are fearing about the kind of illnesses that they would get in old age. And I also think about stigma, not only how we perceive the elderly, of which I'm rapidly approaching, but also how self-stigma can affect a lot of what we're talking about in terms of recruiting participants for studies and stepping forward for early treatment. Because I know that a lot of people kind of freak out about their early signs that they're noticing, and they try to cover, they try to hide that. So I was just wondering what you thought about how we as a culture, our ageism, relates to some of the things that you're talking about today.
well, I think you're pointing to something that's absolutely true. I mean, it's just absolutely the case. And within the context of the A4 study that I mentioned to you, we're actually doing a really impressive study called the Socrates study. This is run by Jason Karlowicz out of the University of Pennsylvania, in which they're interviewing individuals who are positive over a period of time, just to ask them, what's changed. And in fact, amazing, perhaps not surprisingly, there is a fair amount of reporting of feeling of loss of control, sense of being perceived as being ill. And I think that, in fact, that stigma is a rather large issue in terms of treating until we have a treatment, right? And that's the big dilemma. Now, it's a very interesting question, because oftentimes people do make fun of memory loss, right? And I was sharing a panel a few years ago with one of my geriatrician colleagues, who started the lecture making a joke about somebody's memory loss and their pain, their arthritic pain. Well, don't worry about it, because you'll forget about it tomorrow. And the audience, who was primarily older, did not find that funny. So I think it's really, it's always good to be able to make fun of ourselves or to have humor inserted. But I think it's really important to realize that it is stigmatizing, and people do care. So I also think that you're right, that the concern about age is combined with the concern about disease. And in fact, that probably makes the problem even more prominent. So,
I see a question over here.
Hi.
Hi.
We met earlier today.
yes.
So a number of years ago, we did some studies in the VA, and we found that ARBs, the angiotensin blockers, and before that, statins, we did some studies on statins, tended to be protective in terms of occurrence of dementia and Alzheimer's disease in a fairly large population-based study. But my question, I guess, is more of a public health-oriented question. As the population ages and we're dealing with an increase in the occurrence of Alzheimer's disease, are we equipped to handle that in terms of the healthcare resources that may be required in terms of the care of these patients and the toll it may take on the families that are involved?
Yeah. It's really the big question that we all want to know. The possibility, I mean, it is possible if you work for the association, the Alzheimer's Association, we know that the numbers are huge and they're getting bigger and it's very expensive. And I do believe that's true. But I also think there's trends of change that may change the actual economic formulas. So one trend of change is that the onset is coming later. So if the onset is coming later but longevity is not increasing that much, it might be a more compressed period of time. The onset seems in some cases, or the disease seems to be milder even at these older ages. And so that's another issue to keep in mind. The additional possibility is that we have competing risks. The other issue, and this is really who pays, a lot more of the care is being absorbed by family members. It's conceivable that the patient with Alzheimer's disease has a 60-year-old child who decides, oh, I think I'll retire early and do this instead of continuing to work. So there's that side of the spectrum, and that is the biggest piece of care, right? And those dollars are always talked about together, but who's paying them is the big question. And so I'm not always convinced it's going to bankrupt us. I think it's going to bankrupt the quality of our lives if we're left taking care of aging individuals. The other problem that's really not addressed in terms of the finance of this is that as we're expecting people to work longer, right, we're raising the age of retirement. In fact, if you think of the continuum of cognitive loss accelerating with the presence of the disease and age, your loss now can include not only your financial aspect of this is not only that care, but the loss of wages, or very often this age group is actually doing real work, again, maybe not receiving money for it, but doing real work that has value, taking care of grandchildren, doing volunteer work in certain places. And so I think that economy has to be considered, and it may be the shift in economy as opposed to the end of life.
I think we have time for one more question over here.
Thank you. I've learned so much today, so thank you very much. And I think we're all sensitized to our own increasing risk and the numbers. But is it not the case that age-adjusted rates are actually decreasing? And I'm an environmental health scientist, so I couldn't help but notice a lot of the risk factors I think of as comorbidities are also associated with air pollution. And so some have attributed this decline to policies and improvement of air quality. So I wonder if you could speak
Yeah, it's
to
a
that.
great question. In fact, the way the story goes is that the number, at least as I understand it, the numbers are declining in developed countries, right? High-income countries are showing declines. Not true in developing countries where the largest populations are, right? But in fact, one might argue that if they get to manage their environment and their health conditions, that in fact they could also see a decrease. So the numbers are not disappearing, and if one argues that you're going to have some additional longevity coming, we have some, it's not, but that in fact the prevalence could be maintained or increased. And the actual number of people, even though the incidence is not going up, the actual number of people remains high. But I do agree, and I actually speak to that as one of the measures of progress. As I said, when I entered this field, I worked originally in a neurology department. People told me that nobody cares about cognition. I mean, it's just not important, unless there's completely demented or there's everybody else. They're just average. And that's really changed. The AAN has actually agreed that it's legitimate to consider diagnosing, treating, and managing cognitive complaints across the age spectrum. So that's a big difference. And to me, in a society that becomes only more and more technological, you're maintaining your brain, as we say sort of colloquially, or even growing your brain in your youngest stages is really critical. So.
I think that brings us to the end here.
Please join me in thanking our panel.
Thank you. That's great.